It's my pleasure today to introduce a UMass Chan Medical School alumnus who has come back to give a grand rounds. He reminds me that we did a rotation together when you were a medical student.
2012.
2012. What was I working on then?
A lot of different things, I think.
I think it was probably Stop PD probably during that time. And we were at the farmhouse.
Yes.
Yeah. And well, that reminds me, we are looking for continuing to look for patients with treatment-resistant depression to participate in our psychedelic study, the psilocybin study, which will also be the topic of Dr. King's talk today. So after graduating from UMass Chan Medical School, Dr. King completed his residency in psychiatry at MGH McLean, followed by a fellowship in consultation liaison psychiatry at MGH and a research fellowship at the MGH Cardiac Psychiatry Research Program. Dr. King is particularly interested in optimization of therapy paradigms within psychedelic research, as well as the use of psychedelic-assisted therapies in disorders at the mind-body interface. Dr. King is currently the principal investigator in a pilot study exploring the feasibility of psilocybin-assisted therapy for irritable bowel syndrome, and is the study psychiatrist for a neuroimaging study examining the effects of MDMA-assisted therapy for fibromyalgia. He is also co-developing the Harvard Interdisciplinary Program in Psychedelics with colleagues at Brigham and Women's and BI Deaconess, a program that provides education and training in psychedelic-assisted therapies for clinicians across the Harvard Medical School community. The title of Dr. King's talk today is Psychedelics and Psychedelic-Assisted Therapies, What We Know and What Are the Challenges. Let's give a warm welcome to returning UMass Medical School alumnus, Dr. Franklin King.
Thank you so much, Tony. It's great to be back here. I've taken a lot of tests in this room. So the talk today is on really sort of a broad overview of both the classic psychedelics and the empathogens. So I'm not going to be touching on ketamine. That's sort of a question mark, I think, as to whether it fits in the realm of psychedelics or not. I will talk a little bit about sort of how they've been used, how the therapy works. Not going to really talk a whole lot about specific clinical trials, but I will come back at the end after we discuss some of the mechanisms with some of the issues that were raised at the advisory committee appointed by the FDA that led to the rejection of MDMA this August, because I imagine that's probably on many people's minds. First, I like to kind of step back and frame the question as to why we're talking about psychedelics, because this is a pretty marked shift from when I was in medical school. Nobody was talking about psychedelics, to now where we're talking about giving psychedelics to really some of our most vulnerable patients. So we basically spent 5 decades saying that these are, incredibly dangerous drugs, and now suddenly we want to give them to people with treatment refractory psychiatric conditions. That's really a pretty pronounced about face. And I think sort of the overall picture that we need to be mindful of is that we're kind of past the heyday of the original form of psychopharmacology, right? So late 70s to the 1990s, there were all of these breakthrough treatments. I kind of missed the boat on that in my medical education. And so people are really looking for new treatments amidst these dual public health crises of suicide and overdose, right? And I say that not to be cynical or pessimistic. I'm actually very optimistic about our field and our profession. But just to frame the societal picture is one where people are really looking for something new, which both means that there's a lot of opportunities, but there's also a lot of risks. When people are desperate for new things, it means that they ignore the bad and tend to overhype the benefits of anything that seems to offer promise. So I caution the way we think about psychedelics in this way. Media is not very helpful for this, contributed a lot to hype. There's a lot of money being thrown around. People love saying the term paradigm shift. And what's important to me is really how can we ensure that these enter into medicine and into psychiatry in a way that's safe, that's equitable, that people can access, and that's actually going to be most effective. So when we're talking about psychedelics, we're sort of talking about 2 classes. There's the classical psychedelics, and those are the things that do all the stuff that people think about when you mention something like LSD. A prototypical classical psychedelic causes a profound change in consciousness, People often feel that something deeply important or meaningful has happened. There's this term ego dissolution, which refers to the felt experiential dissolving of the boundary between subjectivity and objectivity, or of the difference between the internal and the external world. And there's obviously an enriched sensory or phenomenal experience, which is what people think about when they hear the term psychedelic, visual hallucinations, for example. There's another class of psychedelics, the atypical psychedelics, otherwise known as the empathogens, of which MDMA is the prototypical example. And these also cause a change in consciousness, but not usually with ego dissolution and all of the stuff that I just told you about, not typically with visual hallucinations. MDMA and the empathogen class are associated with increased trust, with empathy. They're also called the prosocial psychedelics. People tend to feel more socially connected, and there's a sort of enrichment or an enhancement of tactile stimulation as well. Both of these are of great interest, not just because of what they seem to do, but because of the apparent potential fact that a short application of these can lead to these really long-term, durable changes over time. So when we're talking about these different pharmacological classes, we're thinking about the tryptamines and the phenethylamines. The tryptamines are by far, in the modern day at least, the most widely researched class of psychedelics. These include psilocybin, which is found in psychedelic mushrooms. It's actually a prodrug. It's metabolized to psilocin. That's what has activity in the central nervous system. Dimethyltryptamine, 5-MeO dimethyltryptamine, DMT. These are ultra-short-acting psychedelics that have to be delivered parenterally. I'm not going to come back to them in this talk, but there is some research going on with both of those. And then lastly, LSD, which is actually its own little pharmacological class of ergolines, but it looks and behaves enough like a tryptamine that we sort of think of it as being tryptamine-like. That's what's pictured there in the molecular structure at the top of the slide. Phenethylamines are the other broad class, and this is a very interesting class for anybody in pharmacology in any subject because we use phenethylamines all over medicine. We use them in the ICU. Pressors are phenethylamines. We use them when we have a cold, like pseudoephedrine or phenylephrine, which we now know actually doesn't work from the FDA last summer, right? Anti-Parkinson agents, antidepressants, bronchodilators, phenethylamines all over the place, and there are hundreds of phenethylamine psychedelics as well. I say this is an interesting class because MDMA is a phenethylamine, but other than MDMA, there's almost no research either in the 50s and 60s or in the modern era of psychedelic research that has examined the effects of all of these different psychedelic phenethylamines. But mescaline and 2CB are two others that there's been just a little tiny bit of research on that some of you in the audience may have heard of. The pharmacology of the classical psychedelics is primarily via agonist activity at the 5-HT2A receptor, the serotonin 2A receptor, or via partial agonist activity. That's been shown in several studies where this has been established by treating people with ketanserin, which in humans is a selective 5-HT2A antagonist, followed by the administration. It's been done with psilocybin and LSD. You're looking here at a graph of people who were administered LSD. All right, so the folks in the line that you're seeing in the middle of the figure are showing that this is just looking at subjective effects of the drug administration. So the folks given LSD are having an expected drug effect, whereas the other two groups, which essentially are both having no response, are the placebo group and then the third group, which was given ketanserin and then LSD, just showing the fact that by blocking the 2A receptor, you're going to completely, fully antagonize the effects of psychedelics. It can also be used to terminate a psychedelic experience. We don't use this in the United States, but it's available in Europe. And there was a study that was published last summer looking at the termination of LSD mid-session using ketanserin. This is also why if you had to terminate a psychedelic, for example, in the emergency room, you should be using a 5-HT2A receptor antagonist such as an atypical antipsychotic. And this has actually been studied by a Swiss group that gave risperidone as compared to haloperidol after administering people psilocybin mushrooms. Risperidone more completely antagonized the effects as expected, and haloperidol actually made some of the symptoms worse. So a couple of reasons to use the atypicals instead of the typicals. All right, so the empathogens, on the other hand, have a different pharmacology. So MDMA is basically just a monoamine releasing agent. It releases serotonin, dopamine, and norepinephrine. The primary prosocial effects are thought to be due to serotonin release, but MDMA is also a stimulant. So the MA in MDMA is methamphetamine. Okay, so it has some activity releasing dopamine and norepinephrine, probably related to the fact that it causes some euphoria as opposed to some of the classic psychedelics. And SSRIs and SNRIs will antagonize pretty effectively the effects of MDMA. So people have to come off of SSRIs and SNRIs before enrolling in the clinical studies that you've heard about with MDMA. This has also been shown. What I'm showing you here is the same Swiss psychedelic pharmacology research group, where they found that essentially treating someone with citalopram before administering MDMA prevented the effects of MDMA in a manner that was similar to just giving somebody placebo. Physiologic and psychologic adverse effects. So for the classic psychedelics, there's some somatic side effects that are fairly common. About half of people in all the clinical trials that have been done in the last 20 years have reported at some point headache, fatigue, nausea, sometimes dizziness is another one. These tend to not characterize the entire session. So remember, psilocybin lasts for about 5 to 6 hours, and the sessions usually are going to be 7 to 8 hours long. But at some point, people are going to report one of these things in the course of the session. There's a mild sympathetic increase, but classic psychedelics are not sympathomimetics. Okay, so generally in overdose with classical psychedelics, you're not going to see something like serotonin syndrome. You're not going to see extreme hypertension or tachycardia. Psychiatric side effects, people can get very anxious, they can get dysphoric, and this can slide all the way up into frank delusions, into paranoia, right? The so-called challenging psychological experiences. Chronic adverse effects, this is theoretical, but important to sort of think about, particularly if people have patients who are interested in microdosing. How many people here have heard of fen-phen? Is familiar in the audience? Yeah, so fen-phen was a drug marketed for weight loss in the 1990s. It was two different phenethylamine stimulants, fenfluramine and phentermine, and it caused a significant incidence of cardiac valvular leaflet fibrosis and pulmonary hypertension. And it was found that this was then pulled from the market. It's now used to treat a rare seizure disorder by special approval. But it was found that cardiac valvular leaflets have 5-HT2B receptors. Fenfluramine stimulated these receptors, and that had a fibroblastogenic effect, which caused fibrosis of these leaflets, leading to cardiac outcomes. Classic psychedelics, as well as MDMA, also are agonists at this receptor. So there's a theoretical risk that repetitive use of psychedelics could initiate a similar response. The reason I say theoretical is that given the fact that there are so many people out there at this point who have repeatedly exposed themselves to psychedelics, one would think that we would have seen incidents of this, and we have not yet done that. But it remains a potential risk that I always tell people about if they're thinking that they're going to go do this, aside from general harm reduction practices. I'll just mention here that a group that I'm working with at MGH is enrolling people in the Center for Arrhythmia Medicine. And this is a study doing echocardiography on people who are chronic heavy psychedelic users as compared to controls, to try to see if we can find any incidents of this. It's a really important question that's unresolved here. MDMA has a different set of acute adverse effects. Many of them are kind of similar to what you would see in stimulants in general, particularly amphetamine stimulants. MDMA fairly commonly causes jaw clenching or bruxism. In higher doses particularly, it can raise body temperature, likely due to serotonin release. There's SIADH associated with this. People can get a little bit nauseous on this, appetite suppression. And MDMA is more of a sympathomimetic, right? So this is a stimulant. High doses of MDMA are going to really drive up sympathetic discharge. You're going to get hypertension and tachycardia. So overdose on MDMA is actually much more likely and possible than with the classic psychedelics such as psilocybin. Anxiety tends to be the side effect of MDMA. People usually do not develop frank paranoia or delusions the way they can with classical psychedelics. Again, question marks on chronic toxicity with MDMA. So certainly many of you have probably heard this idea, this sort of just lives in the conception of the lay public that MDMA puts holes in people's brains. This is based largely on research with animal models of MDMA giving extraordinarily high doses that really would be, frankly, toxic to human beings, and finding that there were various neurological sequelae of doing so. The one study that has been conducted on people who only use MDMA and don't use many other drugs, which is a very population that's very difficult to find because people who use MDMA tend to use a lot of other club drugs and party drugs, has not found really any sort of neuropsychological indications that there's any chronic neurological deficits. But it's a single study, probably limited conclusions can be drawn from this. And we do know that chronic heavy users have a decreased 5-HT serotonin receptor density, probably due to chronic serotonin stimulation. So there is a potential risk here worth thinking about. This is just showing the autonomic effects. On the left, you're looking at systolic over diastolic blood pressure across a 6-hour time course for psilocybin. You can see, like I said, this is not sort of a sympathomimetic. There's sort of a mild sympathetic increase on average. This group's blood pressure raised at its peak by about 15 millimeters of mercury above baseline. I know that the details on the right are probably a little bit tough to see, but this is simply showing a number of different doses of LSD, as well as placebo, as well as people who had been pretreated with ketanserin and then LSD. And all you need to look for is the blue triangles or the blue line, which is showing the highest dose of LSD, which is going to be at the top of all of those curves, looking at blood pressure, heart rate, and temperature, just to show that there is a dose-response relationship to this phenomenon, but that the maximum, again, impact on blood pressure and heart rate is about 15 millimeters of mercury, 15 to 20 beats per minute elevation here. Tachyphylaxis, this is something that we see with antidepressants, right? So this is the inability to achieve a previously routinely achieved effect of a drug. And this is something that with classic psychedelics develops quite quickly, right? So what this means is that someone who self-administers a psychedelic such as psilocybin or LSD, a classic psychedelic, for 2, 3, 4 days is going to have a complete inability to achieve a psychedelic effect after several days of repeated self-administration or repeated administration. And so these are substances that we tend to not see either biological dependence, but we also tend to not see psychological dependence in the way that we see with something like cannabis, where no matter how much cannabis people are ingesting or using, there still is the ability to achieve some kind of psychotropic effect from this. We don't have a lot of details on why this occurs. In animal models, it appears to be related to downregulation of postsynaptic 5-HT2A receptors. And there's cross-tolerance that we know develops between different agents. So if somebody were using psilocybin for several days and then LSD, there would be an inability to achieve an effect here. MDMA is a little bit different. So MDMA definitely does have some abuse potential. It causes more euphoria, as I mentioned before. It has that sympathetic, has that stimulant built into it. There's some dopamine releasing activity. And so there is, it's not very common, but particularly I think they see this more in Europe than we do in the United States, where MDMA tends to be used in higher numbers than here. There is MDMA use disorder, where people sort of use this repeatedly in a manner that's more in the form of a classic addiction. So psychological safety, what's one of the many things that's really interesting about psychedelics is that, when you're running clinical trial, you want to be looking at physiological safety, you want to be looking at toxicity. Those tend to be less important for something like a classic psychedelic. And really what you want to be thinking more of is psychological safety. And we don't usually think about that when we're doing clinical studies. That makes this work pretty unique. As I'll mention when we come back to sort of how the therapy works or how the psychological support model works for this, when people develop things like anxiety or dysphoria in the midst of a psilocybin session, for example, this isn't something where you're going to be reaching for a benzo or a neuroleptic. Now, for study protocols, you're going to have one available in case it's needed. But this is something more where no matter what the valence of the feeling that's coming up, be it positive or negative, the preparation work that goes into preparing the patient to undergo the psychedelic session is really about them being able to be open and curious about anything that comes up, be it positive or negative. Okay, so this is not a type of therapy where we sort of look at negative feelings as necessarily being bad and that we need to sort of treat them with something like a PRN. Now, there's another category of kind of psychological safety that we also need to think about, which is this kind of large question of, can psychedelic use lead to something like a prolonged psychosis? Can it lead to first episode psychosis? Can it cause HPPD? The latter, HPPD, is the persistence of usually visual phenomena after being exposed to a psychedelic associated with some degree of distress. And both prolonged psychosis and HPPD were seen quite quickly after LSD started being used. So LSD was discovered in the middle of, I think it was discovered in 1943, started being used in earnest in psychiatry in the early 1950s, and it was totally unregulated. And so a lot of work with LSD in the 50s was not research, it was just actually using LSD in clinical settings. And pretty quickly, people started describing that there were people who had these sort of prolonged psychotic reactions, as well as what we now call HPPD, sort of persistent visual effects, seen quite quickly. And what's interesting is we have not seen any incidents of this in any of the modern clinical trials. Now, less than, I think, 1,000 people still have been administered a psychedelic drug, mostly psilocybin, in the modern era of research. So the numbers are still much smaller. So that's one possibility. The other, however, that I think is potentially more worth considering is that LSD is much longer acting, which can make it more challenging for people. LSD also is a D2 partial agonist. So psilocybin doesn't really have appreciable effects at the D2 receptor, whereas LSD does. And so there may be more of a propensity for LSD to induce these syndromes of sort of persistent visual effects or of a more prolonged psychotic reaction than psilocybin does. There are some studies that have used LSD, but there has not been anywhere near as much focus on LSD in the 21st century as there has been with psilocybin. The other question is, can this lead to an increased incidence of first episode psychosis or chronic psychotic disorder, schizophrenia? My clinical work is in the psychiatric emergency room. I've certainly seen people who've come in with psychosis or mania with some sort of temporal relationship with psychedelics. I always want to write these up as a case series, but the confounding issue is that almost every single person has also been using cannabis daily and chronically. And this is sort of an issue across the board. People who tend to find their way to using psychedelics are also people who are using other substances, but it remains a potential risk, and we don't know the answer to this. The population level data that's been analyzed is somewhat encouraging, but limited in terms of what I'm telling you. So one is that there was a Scandinavian twin study looking at a longitudinal relationship between incidence of first episode psychosis and psychedelic use, not finding an association. There was a survey study in the UK and North America that was published, I think, last year, over time, looking at incidence of psychotic symptoms in people who were using psychedelics and did not find an association. But this is hardly enough to base any firm conclusions on. There is some signal from those studies that psychedelic use may be associated with the incidence of mania. And I personally think, given just what I've seen in the emergency room, that probably the relationship between either causing a manic episode or destabilizing people with bipolar disorder type 1 is likely more of an issue than sort of the development of a chronic psychotic disorder. But that's opinion, and really we need a lot more research to answer this question. In terms of screening, every study, or nearly every study that I'm aware of that's applied psychedelics in this era, in the 21st century, has screened out anyone who has a history of psychotic episode of any kind, be it effective or non-effective. And most studies will also exclude people who have, and also bipolar disorder type 1, and often type 2 as well. And almost every study in the United States has been even more restrictive, where we screen out people as well who have a primary family member with either type 1 bipolar disorder or schizophrenia, basically trying to remove people who might be genetically loaded or predisposed to developing one of these two conditions. So now I want to talk to you a little bit about how the therapy works and these sort of two paradigms, one of which is used extensively in research, one of which is sort of theoretical interest, but for the most part has not been used in research, at least in the 21st century. And that is the first here, which is psycholytic psychotherapy. In the 1950s, when LSD was just widely used in psychiatry, this was obviously the middle of the 20th century. Our field was dominated by psychoanalysis and psychoanalytic conceptions of illness. And really one of the things that you really want to work on with patients from a psychoanalytical framework is softening or reducing ego defenses, the defenses of the things that the patient throws up that get in the way of the therapy and get in the way of them kind of getting to where they want to be, or getting what they want out of the psychotherapy, right? And so through this lens, the initial applications of LSD, well, first, in the very early years of LSD, it was thought to be a mimic of psychosis. But that pretty quickly fell out of favor. That was called the psychotomimetic model. And then people became disinterested in that, started using a psychoanalytic framework to look at what LSD was doing. And through that lens, proposed essentially that LSD was a softener of ego defenses. And so this was a form of therapy, or gave rise to a form of therapy called psycholytic psychotherapy, psychedelic psychotherapy. And this really didn't change the actual structure of therapy. Essentially, the way psycholytic therapy works, and there are people who continue to do this using ketamine in the modern era. But the idea behind psycholytic therapy is that you don't really change the therapy to be specifically focused on the administration of a psychedelic. Rather, you take a pre-existing form of therapy. In this case, in the 50s, it was either psychoanalysis or psychoanalytic psychotherapy, psychodynamic psychotherapy. That would be many sessions per week for many months and often more than a year, sometimes many years. And many sessions, maybe one session a week or every other week, the patient would administer a low or a moderate dose of a psychedelic, in this case, usually LSD. And the idea was that by softening the ego defenses, you might be able to sort of speed up the therapeutic effect of the psychotherapy, or sort of catalyze therapeutic breakthroughs a little bit more quickly. But the therapy wasn't actually constructed around the psychedelic, okay? And this was used in both North America and Europe. Europe never really changed. So Europe continued doing psychedelic research a little bit longer than the United States did, right up until the 1970s and 80s. They continued kind of using this model. But in the early 1960s in North America, you had a lot of different things kind of come together to form the idea behind this new therapy, which is called peak psychotherapy or psychedelic psychotherapy. And so what happened there? Well, in the world of psychology, not psychiatry, you had Abe Maslow, Harvard psychologist who was running the American Psychological Association. He was very interested in transcendent states. He wrote on psychedelics. He never got involved in psychedelic research, but he wasn't interested in psychedelics per se. He was interested in the sort of idea of the peak experience. He wrote a very interesting book called Religions, Values, and Peak Experiences, where he talks about this idea that transcendent states can be therapeutic and helpful, and that we ought to bring them into the world of mental health. So this kind of aligned with certain strands of the zeitgeist. There was interest in sort of humanistic psychiatry. And simultaneously, a lot of people who were working with psychedelics started looking to indigenous models of how psychedelics had been used in much higher doses. And that sort of a ceremonial use of psychedelics in community structures and indigenous cultures usually had a lot of preparation, and then there would be this big ritual where people would take a high dose of a psychedelic, and then there'd be something that would happen after that. And so all of this kind of came together for this new form of therapy that was completely constructed around the psychedelic experience. And rather than taking a pre-existing therapy with a lower or moderate dose of, for example, LSD, there would be many preparation sessions, usually just one, sometimes two psychedelic sessions, and then a number of integration sessions that were aimed at helping the person kind of figure out what insights they had, why they were important, how can they build those into their life in a sort of sustainable way. So that was called psychedelic psychotherapy. And that was resurrected at the end of the 20th century in these research models, primarily initially through Johns Hopkins, as well as MAPS with MDMA, and called psychedelic assisted psychotherapy, which is the term that generally has been used today. I mentioned mystical experience. So there was a lot of sort of intentional use of suggestibility in the preparation in this early model. We don't focus on that quite as much in the modern model of psychedelic assisted psychotherapy. This is just an image of a room where psychedelic assisted psychotherapy is being conducted. You can see there's a blood pressure monitor in there. It's much nicer than the room that we're using at MGH, like 100 times nicer. But what you can see there is that there's 2 chairs, so there's usually 2 therapists in the room. Sessions are long, right? They're going to be 6 to 8 hours. You have to monitor the people. Most studies are going to have to check their vital signs. And then there's also headphones. And so this is not, this is distinct, or this is quite different, I think, than the way people tend to use psychedelics recreationally. The whole purpose of this is to have what's called an internal experience. So people are given eye shades, they're given headphones, music is very important, and they're encouraged really to spend as much time as possible, quote unquote, inside. All right, there's going to be ample time for talking in the integration therapy sessions that occur after the psychedelic session. But really, this is the opportunity, so the idea goes, for the person to just sort of look inward and sort of see whatever comes up. And to approach any content, like I mentioned, be it, sublime or terrifying, with an attitude of openness and curiosity, and just sort of see what comes up and try to kind of look at it in a mindful way, in a non-judging way. Set and setting, you've all heard the terms, I'm sure. Set refers to the mindset, so we address that via the preparation, and then the setting also is important, right? So people tend to have had paranoid reactions when there was work being done in very sterile hospital settings in the 1960s. So that led to this idea that we really have to try to make the environment as soft as possible, within the limitations, obviously, of the modern medical system. This is a very resource-intensive model. So this is not a chromosome. This is showing. This is the MAPS therapy model, the Lykos therapy model. So the crimson bands are the 3 8-hour MDMA sessions. The orange bands are 3 90-minute to 120-minute prep sessions, and then the green are 9 roughly 2-hour integration sessions, all with 2 therapists. All right, so 1 patient, 2 therapists for all of this. This is hugely resource intensive. So when these treatments eventually make their way through the FDA, there's a lot of question marks that we were just talking about in terms of how to even schedule these things, how we're going to reimburse, how this is going to work. And this is what I mean when I talk about accessibility and equitability. It's going to be a lot of things to work out here. Now, I said I'm not going to go through most of the clinical trials. There's so many now. It's hard to sort of pick which one to focus on, but this is an important one here. This was published by Compass in November 2022, so this is 2 years old at this point. And this model used a single dose of psilocybin for treatment-resistant depression. And this is, I think, the same way that it's being done here. You guys, pretty amazingly, are a clinical site for this, for the phase 3. So this used a placebo dose of psilocybin at 1 milligram to try to mitigate or to mimic the effects of psychedelics. A lot of these studies use a very low dose of the same psychedelic being tested as the placebo, compared to a moderate dose of psilocybin, 10 milligrams, compared to a high dose that's enough to induce what we would call a complete psychedelic experience in most people. All right. And what they found is that looking at change in MADRS over time up to week 12, that there was a statistically significant difference at the endpoint between the group that got 25 milligrams as compared to either the mid dose or the single dose. And I think this aspect of this study is often unappreciated, that there is something about the dose that actually matters as well here. All right. I also show this study because this is by far the largest psychedelic study that's been published to date, like by more than twice as many people as the second largest study, which is about 100 people. This is 233 participants. And I emphasize that because it was published in New England Journal of Medicine. I emphasize that because this was a study where it was found that suicidal ideation or behavior or self-injury had a dose-response relationship in these 3 groups. Many other psychedelic studies have had incidences of suicidality, but it's been comparable between the placebo and the active group. And this study actually found that there seemed to be a relationship between the highest incidence of these events and the highest dose, which was also the most effective dose. So I think given that this is the largest study that we've seen, and we've seen this is something that we may expect maybe more of a risk that we need to anticipate, essentially, that we may see more of this. Okay, particularly obviously in a high-risk population like TRD. Now, these are the only two phase 3 clinical trials that have been published yet on using a psychedelic assisted therapy. This is the Lykos MAPS MDMA assisted therapy for PTSD studies. I'm not going to go through the details of this. I'm happy to share my slides, by the way, with anybody who'd like to look at them. But I show these only just because this is what's probably on everybody's mind. These are the two trials, the data of which were reviewed in June by the advisory committee and in August by the FDA. The only new drug application that's been filed to date with a psychedelic. This is the same study with the chromosome picture that I showed you. So these folks got 3 doses of MDMA with all of the therapy I told you about, or they got placebo with all the therapy I told you about. So the placebo group was exposed to quite a bit of two therapist dyad sessions throughout the course of this. All right, the red is obviously the group that was given MDMA. And I'll come back to what happened with the FDA at the end of this. Lastly, this is an area that's really interesting to me and that I think actually holds potentially even more promise than some of the psychiatric or classic psychiatric indications as a CL psychiatrist, which is using psilocybin-assisted therapy for end-of-life depression syndromes and anxiety syndromes. So this all started in the early 1960s at Cook County Hospital. There was an anesthesiologist by the name of Eric Kast, did a study comparing LSD to morphine in people who had cancer and pain. And he found that LSD had a greater impact than morphine, substantially, and that people were reporting a decrease in their response to pain, sometimes in some cases for several days out. So we continued doing more research with LSD, ended up really noticing that it wasn't so much an analgesic effect per se, but rather that people were having a diminished emotional response to their pain. They were still having pain, but it wasn't impacting them as negatively as it had been before. So this is one of the sort of discoveries that went into this sort of looking at psychedelics in terms of this peak experience. So really, if you Google Eric Kast and read about his work, there's a lot of interesting old JAMA medicine, JAMA papers from the early 1960s talking about his sort of transition into being more of a psychiatric researcher. Became a really promising area of research in the late 1960s. It was kind of like the next thing that was being studied when the research all sort of crumbled. By early 1970s, there was no more psychedelic research in the US. And this idea was resurrected in the 2010s, first with a pilot study at UCLA that I don't have on here. And then in 2016, there was this pair of studies by the group at NYU, group at Hopkins, still leaders in this field, looking at single-dose psilocybin-assisted therapy for basically an aggregate group of symptoms. It had to be depression or anxiety syndromes associated with advanced stage cancer. Both basically two separate trials, but both used essentially the same protocol. Both used a crossover design. People really randomized to immediate or delayed treatment. And this is one of these studies that kind of had these too good to be true findings, where you had people who were given a single psychedelic session 6 months out, the majority reporting substantial reductions in depression and anxiety. Right, so this is one of these, it's got a lot of press, a lot of attention, and then you have people running around saying, well, you just have like 1 dose of psychedelic, like totally cured these people. I just think it's a dangerous way of thinking about things, but I do think that this is a very promising area of research. Nothing else of great significance, I should say, has been published, but there are a number of studies that are going on in this population right now. My colleague Yvonne Bosant over at Dana-Farber this year, I mentioned him, he just completed the first psilocybin-assisted therapy study ever conducted in a hospice setting. So people who are actually really at the end of life. And this was also the first study. He has the honor of being the first study since the days of Timothy Leary, if you could even call that research, that was conducted anywhere at Harvard since the 1960s. So that paper will be coming out hopefully soon. To totally switch gears and tell you just a little bit about the mechanisms and how we think psychedelics actually work. How many people have heard of the default mode network? If you're interested in psychedelics, you've definitely heard of it. Okay. So default mode network, we think of the brain now in terms of networks, right? So default mode network, is the network. We've known about it for about 25 years, and it's involved with introspection, daydreaming, mind wandering, and what we call self-referential thoughts. It's associated with our sense of self. It activates, we sort of think about memory, personal narratives, things like that. And we can activate this in a scanner. We can see it on fMRI by just having somebody lie supine and think about nothing in particular, as opposed to doing a task, which is when you turn off the default mode network, okay? So when somebody runs into the room and is like, hey, can you read this paper? Hey, can you do this calculus problem? Your default mode network is essentially going to diminish in activity, and sort of more externally focused networks are going to activate. So their default mode network is competitive in normal states with these externally directed other networks of the brain. I'll come back to why I say that in a moment. Default mode network is also associated with a number of different entities in psychiatry. I only mention rumination because the research is strongest, the data are strongest to support that the default mode network is pretty clearly implicated in rumination. And that shouldn't be surprising because this is a network that's most associated with kind of the way we think about ourselves. Rumination, of course, being this very repetitive, negative, and self-directed, importantly, it has to be self-directed thinking, not isolated to depression. People can ruminate and not have depression. We can see it in anxiety, we see it in PTSD, we can see it in substance use disorders, right? So my colleague and the associate director of the Center for Neuroscience of Psychedelics at MGH is doing a study using psilocybin-assisted therapy for treatment-resistant depression, but she's specifically looking at changes in rumination for this very reason. And it's going to my knowledge, still be the first study to enroll clinical patients as opposed to healthy normals, and do imaging, do task neuroimaging while they're on psilocybin in the middle of the session. Just a plug for that. All right, so bring up default mode network because this is one of the prime mechanisms by which we think psychedelics work. Decreased or disrupted in some other way. You can either basically dial down the activity of a node in the default mode network, or you can split the nodes apart so they can't communicate quite as effectively. And both have been seen in different studies of different psychedelics, including ayahuasca, psilocybin, and LSD. And there's some evidence to suggest that the intensity of the subjective effects on an individual basis correlates with the magnitude of disruption of the default mode network. So this is interesting because this is a network that's associated with our sense of self, and psychedelics are known to disrupt it, and psychedelics also produce ego dissolution. So this may be a basis or part of the basis behind why people experience this dissolving of the sense of self on a high dose of a psychedelic agent. Clinical implications here, we can target rumination and we can target self-referential thinking. This tends to be something that is a very treatment-resistant aspect of depression. It tends to not respond as well to treatment. And it's a transdiagnostic issue. And so if we can find a sort of transdiagnostic way to modulate these psychiatric illnesses, this is one of sort of the more neurochemically based or neural circuitry based theories of why psychedelics may hold such promise across kind of a wide variety of potential clinical indications. Another aspect that I want to just touch on is the claustrum. How much do people know about the claustrum? So on your mind with every patient you see, right? So the claustrum is a very kind of enigmatic part of our brain. So it's buried deep beneath the cortex, and it connects to literally everything. And the claustrum has been often referred to as the brain's conductor. One of the things that we think that the claustrum does, it essentially is the director. It controls our thought in a top-down fashion, which is to say that it's implicated among certain other networks and components in being the part of the brain that governs the switching between different networks. And so when I mention, if you're sort of daydreaming, somebody runs in and says, hey, do this calculus problem, your claustrum is what's going to dial down the default mode network and turn on a task positive network so that you can focus on the external world and do this math problem, okay? The study I'm showing you here is from Johns Hopkins, where they looked at psilocybin causing a disruption in the claustrum's connectivity to both the default mode network and the task positive network. What I'm not showing you here is another study. This is the first imaging study of psilocybin ever done, published in PNAS in 2012. And that study found that rather than the default mode network and task positive network externally facing being competitive, which was seen in normal states, that there was a melding of their activity under the influence of psilocybin. And so these studies together seem to suggest that by disrupting the ability of the claustrum to basically say, default mode network turn down, task positive network turn on, and one is going to be off, one's going to be up, or vice versa, that there's a merging of the two, that this really may be sort of the uniting principle behind why there's this disturbance that psychedelics cause between subjectivity and objectivity, that there's often an experience of the blurring between our internal thoughts and everything going on outside of us. So a lot more to come, really interesting mechanistic research on this. Lastly, before winding back to the FDA decision, is the idea of neuroplasticity. So neuroplasticity is something that hopefully everybody's doing. Hopefully if you're learning something, well, that's neuroplasticity. It's our brain's ability to adapt to change over time. We can do this in many different ways. Some species, not us, we're not lucky enough, can grow new neurons, but you can produce more proteins, you can produce more dendrites, you can strengthen or weaken connections in your brain. And this can occur naturally via experiential change, or it can be drug-induced. And we actually know that antidepressants, among many agents, can induce neuroplasticity to a certain degree. And neuroplasticity is one of the key ways that we're interested in finding to basically treat people's depression, because depression obviously is sort of a learned state of mind. And by inducing a state of neuroplasticity, the idea is that you can kind of unlearn that way of being and that way of thinking. On a very basic level, this is a study published a few years ago looking at neuroplasticity in single neurons in Petri dishes. All the way on the left is VEH, that's just vehicular control, i.e. control. And then the other three are three different psychedelics. The stain is looking at dendritic proteins, and so essentially just showing that psychedelics induce an increase in synaptic density and in proteins associated with synaptic connections. What they then did is they did the same experiment, but they pre-treated the neurons with ketanserin, this 5-HT2A antagonist, and they found that they didn't see this. So this would seem to suggest that this neuroplasticity-inducing effect of these three different psychedelics must be mediated by the 5-HT2A receptor. BDNF is a marker of neuroplasticity. It's a small study conducted at the same Swiss pharmacology group that I mentioned before, using 3 different low doses of intravenous LSD and then measuring plasma BDNF over time, finding that with the highest dose of LSD, there was the greatest increase in BDNF, but all 3 showed an increase in BDNF after LSD administration. And then finally, BDNF itself has a receptor called TrkB. This paper was published last year and generated a significant amount of attention. It's one of these beautiful scientific papers with like 20 different levels of experiments. But essentially what they showed is that every antidepressant they looked at bound quite effectively to TrkB, which is the receptor for BDNF. Essentially that every antidepressant they tested could bind to the receptor that is a marker and an inducer of neuroplasticity. However, they found that LSD bound to TrkB with 1,000-fold greater potency than anything else that they looked at. And they were able to show that this happened independently of 5-HT2A. So I mention this because while the other study that I showed you seems to implicate 5-HT2A in neuroplasticity, this seems to suggest that there is at least a complementary or a parallel pathway. So there may be more than one mechanism via which psychedelics are inducing a state of neuroplasticity. And then finally, the question is, why is it even possible? Why does our brain have the ability to have a psychedelic experience if it's exposed to certain drugs? What we know about the 5-HT2A receptor is that many different models of stress in animals will lead to upregulation or increased expression of 5-HT2A receptors. And so that's interesting, right? So that maybe psychedelics are basically hijacking or mimicking an innately conserved stress response system. Now, how does that make sense? Well, Robin Carhart-Harris, who's done some of the seminal research on psychedelics, moved from Imperial College London to UCSF a couple of years ago, has this idea of pivotal mental states that he's put forth, where he describes pivotal mental states, including psychedelic-induced states, as these transient hyperplastic mind and brain states with exceptional potential for mediating psychological transformation. And these are marked by elevated cortical plasticity and an enhanced rate of associative learning. And the reason, he suggests, based on the fact that we know that 5-HT2A is implicated in animal models of stress, that this may be able to be achieved with psychedelics is that these are states of rapid and deep learning. These are his words. Rapid and deep learning in situations of perceived or actual existential threat or crisis for purposes of catalyzing psychological change when circumstances demand this. So essentially, the theory here is that if you have an organism that is facing an existential threat, that organism is going to need to unlearn a lot of pretty deeply held knowledge and beliefs about how to survive in the environment and adapt to change very, very quickly if it's going to survive. And it appears that in animal models of doing that, we induce an upregulation of this receptor that is implicated in the mechanism of action of psychedelics. That psychedelics, this may be why this receptor system essentially exists, and the mechanism by which psychedelics kind of hijacking this to help us unlearn things that are pretty deeply held, things such as negative self-conception in depression, just as one example. He goes on to say that the role of context in these states is going to be crucially important, right? So if you induce a neuroplastic state, that can be positively or negatively valenced depending on the background of the individual, how much adversity they're bringing into the situation, what actually happens during the situation. We're talking about the psychedelic situation at this point. And then, of course, the immediate aftermath of this. And so this may be why, if somebody has a challenging psychedelic experience, coming into it with a negative mindset, it's totally unsupported. Maybe they're at like a concert or a festival, and then they don't have any support afterwards. This can leave them with lasting psychological damage, which we do see with psychedelics. Whereas somebody who might have the same challenging experience, but it's handled very adeptly with a therapy team, and they're able to sort of deal with it, and they're helped through that process, that they may end up being able to turn it around into a positive psychological outcome. So I think it's important to think about psychedelics as context amplifiers. There's nothing positive or negative intrinsically about psychedelics. It's really the way in which they're administered and what happens during, before, and after the psychedelic session. I promised I would speak just a little bit on the FDA. I think I'll wrap up in time for a couple of questions. But in June of this year, the FDA appointed an advisory committee. These are not members of the FDA. They're people that are waiting to be basically called to evaluate data. So the advisory committee, this was it was live streamed at the end of June, and they raised a number of concerns. They ultimately voted no, both on efficacy and safety, and they raised three different concerns that I've kind of categorized. Okay, so the first were things that the FDA already knew about and that really should have been, and presumably were in the briefing materials that the AdCom received. These were questions on, do we need to collect LFTs at the end of the MDMA session? Why didn't they get post-MDMA EKGs and things like that that really already had been done in earlier phase research? And it's sort of unclear why they were bringing that up, because these trials, the FDA actually had a pretty heavy hand in the design of the actual trials under the Breakthrough Therapy program that the FDA has. The second were issues that I think raised some concern about double standards, which is this question of functional unblinding. You can't blind psychedelics. It's essentially impossible. People know that they've been given, in this case, MDMA versus not. And in these clinical trials, they did assess blinding in terms of both the people giving the MDMA as well as the study participants. Now, the FDA doesn't mandate this, and many studies actually don't check this. This study did. And one notable example of a drug that did get approved that easily causes functional unblinding as well is esketamine. So if this were not an issue with esketamine, I found it sort of questionable why this was being raised by MDMA. And then the third are some issues that really the FDA had spoken to Lykos about years before when they were embarking on their second phase 3, and for reasons that are unclear to me, I'm not associated with Lykos, that they didn't actually check. So for the second clinical trial, they asked them to measure things like euphoria as an adverse event, and they just did not do that. And that led into some of the comments about potential risks of MDMA and its addictive potential raised by the AdCom. So I say, finally, a lot of the stuff that came out in the media was not actually discussed by the advisory committee in any of their rationale in recommending that the FDA reject MDMA-assisted therapy, which the FDA ended up doing in August of this year. Broader challenges where I think the field is now. One is that the FDA's mandate is to evaluate and regulate drugs. The FDA is not set up It's not allowed to evaluate therapy. So if this is really a psychotherapy plus a drug or a psychological support that has to be conducted in a certain way, we don't have the regulatory structures in place to actually evaluate this. Second is that it's very difficult to evaluate psychedelics in an RCT in the first place because the RCTs are looking at very discrete changes. And one of the interesting things about psychedelics is that the subjective experience of the drug is both a consequence of the drug and a therapeutic mechanism. This is different than something like alprazolam. Somebody has a panic attack and they take alprazolam. Their sort of experiential change in the process of going from panicking to not panicking is really unimportant. It's just a pure pharmacological effect. GABA receptor, panic attack gone. Psychedelics are very different. And so how can we actually evaluate this when the sort of experience of the drug is caused by the drug, but it also influences the therapeutic outcome? And I think there's going to be some pressures because of this to devalue the role of the experience, to minimize the importance of the psychological support that's necessary. And I think if we're not careful with this, that this is going to lead to decreased efficacy and also increased harms. And this is my last slide. I just think it's always really important to push against polarized thinking as well as extremes. So issues of hype on the one hand, issues of stigma on the other, continue to be challenges here. There's questions of epistemic injustice. We're standing on the shoulders of millennia of indigenous uses of psychedelics. The ideas behind them come from these cultures. So I think there's some questions of reciprocity. Generalizability, 85% of participants up to this date have been white. Is this really generalizable to the American population? And then questions that I've already mentioned of accessibility. We know it's time consuming, resource intensive. Who's going to actually be able to access these once we get through the FDA? And thanks, I'll stop and hopefully time for one or two questions.
Great. Thank you very much, Franklin. I have a comment and a question. My comment is, those studies of MDMA that were published have since been retracted by the journals. I think 3 of them.
So the journal, so what you're referring to is that in one of the phase 2 clinical trials of MDMA, the study therapist ended up entering into a sexual relationship with the study participant. So this is just egregious misconduct. And the phase 2 papers, that they did not remove the data from that clinical or from that research site. And that was what had made it into those papers. So when removing that, I think there were like 3 or 4 participants who'd gone through that particular clinical site, the data were the same. I'm not sure that I'm the person to speak to this, but what I've seen from sort of critics on both sides of this is that it would have been more appropriate for the journal to allow them to issue a correction because the actual results of the trial, this is phase 2, not phase 3, and were actually the same with or without that study site that should have been excluded, however. I would agree with that.
Yeah, the journal retracted it, and then some of the authors protested, in their, I guess that's published too. But
right.
Here's my question. As you know, and you touched on this, there are in development psychedelic treatments that are short acting, 2 hours, maybe.
Yeah.
There's no time to do psychotherapy. They're sort of developing a model you don't need the psychotherapy. What do you think about that?
I could talk for that on more than an hour. I think with what we know with psychedelics, at this stage, I think it's risky to minimize the role of psychotherapy. But by psychotherapy, I really just mean somebody who knows how to support somebody having a psychedelic experience. And this question of like psychotherapy versus psychological support is its own sort of hot button issue in the field. And I actually don't think that the terms are as important as just somebody who really can take very, very seriously the potential risks, which do include, the risk of boundary violations. It goes way up with these things. People are incredibly vulnerable. They can really fetishize their therapist. When you give somebody these incredibly powerful experiences, as you may have seen this in your study, more with MDMA than psilocybin. But the risks of very positive transference being thrown at a therapist are well documented. Outside of psychedelics, be something very difficult to withstand. And that's a risk, I think, that hasn't been sufficiently discussed. So if you have people that don't have really good kind of like therapist boundary, professional and ethical training, I think that's more of a concern than like what type of therapy. I don't think we have enough evidence to say that like the model that I just showed of psychedelic assisted therapy PrEP integration is like the only way to do this. As for the short acting psychedelics, and my guess is that in 20 years, there's going to be a lot of different models and there's going to be a lot of different drugs. And there's going to be some psychedelics that are prescribed that induce neuroplasticity without any psychedelic psychotropic effect. And I think there's room for lots of different models and different drugs and a lot of different directions that this could go. Yeah.
Thank you. That was great. I think it's a fascinating place in our field. Care to comment on the ballot initiative in Massachusetts and the use of psychedelics in, well, I forget what they're calling it, treatment or something like that?
I think I would prefer to just kind of keep it to the literature and to the science and what we're talking about here. But if you have a question on kind of this.
Where do you think that fits in? There are a bunch of different models for the use of psychedelics, both in sort of spiritual practice, medical practice, and then people are doing them recreationally. Where does the medical model fit in with that? And are there effects between the three?
I would say if you're interested in the effects between kind of different societal models of this, there's a paper called Socio-Psychedelic Imaginaries. It's open access in the European Journal of Futures Research. It's a very thoughtful paper exploring kind of like the social implications of medicalization as well as some of the political contexts from a kind of neutral academic lens. It's one of the most brilliant papers that's out there on psychedelics in general. It's very worth reading. It's called Socio-Psychedelic Imaginaries. Yeah.
Hey, thank you.
Go ahead. Go ahead.
Thank you for your talk. I really appreciated that you went more into like neurobiology, because aside from like Gall Dolan's talk, most psychedelic presenters don't go into that. I kind of do want to mention, and I think part of this is also because this kind of field is being looked under a lens, and I'm not saying if like other lines of work were being looked under a lens that this wouldn't also be the case. But there were other egregious issues in terms of like conflicts of interest, like analysis with the Griffiths paper, the research design with the MDMA trials, and I think I think it's important to kind of talk about that as we sort of figure out the safest way to move forward in interests of caring for these especially vulnerable patient populations like PTSD veterans. The point that I'm trying to really get at is that a lot of private companies like Lycos and such, I think not only can get kind of blinded with passion and care and also profit. And I know traditionally, like we do need pharmaceutical companies to kind of benefit, to kind of support these kinds of studies. But like, I kind of wanted to talk a little bit about maybe getting more like academic institutions or like federal institutions heavily involved in this type of work and kind of taking it away from private institutions, which might not always have the best interest for patients, and kind of ways to go about that. Because I definitely think that, yeah, like kind of like you said, depending on what happens, like it can kind of go either way. And you could say that with other kind of medical interventions, but we want to make sure it kind of does more harm than good.
There are many complex questions that you're referring to there. I think a couple of things that I would mention. So the Congress tucked into a bill, and I can't, it's out there if you Google it, within maybe 3 or 4 months ago, put out a request for anybody to write in basically any concerns or information or opinion that anyone has, particularly looking for professionals, about all of the stuff that you mentioned and all the stuff that I'm talking about. So there's a group at Congress kind of like looking at like potential legislation in the distant future, but also just sort of like gathering information from people all over the country. So you have stuff to say, that'd be a very, important place. So I think ultimately policy at the federal level is probably going to get involved at some point. I'm particularly interested in a lot of the critical issues that you mentioned. I'll just put in a plug. I have a conference that's happening at Harvard Divinity School. Should know the date, but I think it's November 10th and 11th, or 11th and 12th. It's November 11th and 12th. It's about all of these critical issues. So issues of sort of like randomized controlled trial epistemology, ranging all the way down to sort of reciprocity and issues at that level. So that will be a venue where kind of a lot of the stuff that you're referring to will be kind of extensively discussed.
Thank you.
I'll tell you what, the hour's late. Franklin might be able to stay for a minute
Yeah,
to
I'm happy to
answer
stay.
any questions, but thank you very much, Franklin. It's very, very interesting.
Thanks, everyone.